Hello, my name is Savannah Varndell. I worked at Lakewood Hospital with Mary McLaughlin Davis. My high school is Medina Senior High School, and my project was the proposal for an implementation of a discharge coordinator. The hypothesis for the project was that patients who do not follow post-discharge with a physician or complete diagnostic testing face readmission. The implementation of a discharge coordinator would decrease the rate of these readmissions. What's a discharge coordinator? A discharge coordinator is someone who bridges the patient and the rest of the discharge process by making appointments and putting the relevant information together and making sure that the patient understands what is to be expected during and after discharge. Our proposal was to facilitate the transition of care and prevent readmission in less than 30 days through the services of this discharge coordinator. Our project was to really create a proposal for the implementation of a discharge coordinator, which we hoped would decrease the rate of readmissions in the hospital. Our methodology was that prior to the patient's discharge, the discharge coordinator would compile a discharge sheet with scheduled appointments and phone numbers for the offices and facilities. Well, we didn't have a whole lot of time to implement this. It was really only 5 weeks, whereas it would normally take 6 months to a year to fully test this. But for those 5 weeks, I assumed the role of the discharge coordinator and worked out the barriers and the parameters that the job might entail for a future employee. We didn't collect a whole lot of data, but some of the supporting data from other studies done at other hospitals were very positive, although and this is the data that would help support the need for a discharge coordinator. And its readmissions occur within 30 days at a rate of 17.6% for Medicare beneficiaries. And Medicare payment advisory committees estimate that 76% of these may be preventable. That would provide a savings of Medicare for $12 billion per year. And it's not just the money, but the money is a huge part of what this project would entail. And an examination of readmissions to the hospital of Medicare beneficiaries revealed that only half were evaluated by a physician after discharge. Now, part of what the discharge coordinator would do is they would make those appointments and make sure the patient knew how to get to those appointments and that the patient would be at those appointments. And a Kaiser analysis of more than 100,000 hospital discharges found that patients over 65 years of age were 3 times more likely to experience readmission if they were not involved in a post-hospital follow-up visit. The follow-up visits, again, are a huge part of the discharge coordinator's job. That's what they do. The re-engineered hospital discharge program, it demonstrated the effectiveness of a focused discharge plan. These include a nurse discharge advocate, an individualized instruction book, and a follow-up phone call from a pharmacist after discharge. These things are great, but we're starting at a basic level. We're starting at just the discharge coordinator and making the appointments. This is, of course, these things would come next. Our results that we got from the 5 weeks of testing this, we got some strengths and some barriers. The strengths were verbal accolades from patients. Obviously, if you're making the patients happy, you're doing a good job. The presumed decrease in readmissions based on our findings, and of course other findings from other studies. The compliance of patients with non-adherence to discharge plan. We had a patient, he'd never come back for any follow-up appointments, but he kept getting readmitted. And when we set up his appointments for him, he came back for them. We were very happy about that. And the discharge coordinator is a viable member of the interdisciplinary team. They're separate from the social workers, at least at the Cleveland Clinic, and they do their own job. They make the appointments. And the barriers that we found were mostly because we only had that short amount of time. But once they put in place the 6-month to a year program, the barriers would just about go away. Our conclusions were that the implementation of a discharge coordinator would help patients get quality post-hospital care and would be beneficial to both the hospital and its patients. and evidence shows that hospitals with discharge coordinators have fewer readmissions than hospitals without them. And a decrease of hospital readmissions would decrease healthcare costs, improve patient care, and increase healthcare efficiencies. And of course, our recommendations are to engage a discharge coordinator to facilitate the scheduling, follow-up appointments for physicians, clinics, and diagnostic testing. And as I was saying before, they would evaluate the effectiveness in 6-month increments, starting with first 6 months, then a year, and then if they continue to be cost-effective to the hospital, then continue after that every 6 months. And then the goals are to increase patient satisfaction scores and decrease in readmission rates by 5%. And 5% is really a very small percentage for this, and it would be very feasible to attain that. All right, thank you for listening to my program, or my PowerPoint. I would like to thank my mentor, Mary McLaughlin Davis, my peer mentor, Stetson Thacker, and of course the Office of Civic Education Initiatives. Thank you.